Okay, my name is Heun. I'm a consultant psychiatrist, professor of psychiatry, and I want to talk about mental health problems as part of our series in Global Psychiatry Archives. Lots of papers you can see there and also articles anyway. Today we wanted to talk about psychopharmacology in elder people, and there's some general views about that. First is that older people have more physical health problems, and for that reason they may have more medications. And if you have more medications, you possibly have more interactions of medications. So, and this is what the consequences of polypharmacy are. And possibly there's different side effects from different medication, and some of those side effects might be very similar. So psychiatric drugs very often have cardiac, metabolic, and extrapyramidal side effects. So they affect the heart, the metabolism, and the nervous system. There are also other changes in the body, how the body deals with medication. That's what we call pharmacokinetics. And that's very important in general to look at the pros and cons and the benefits and the disadvantage. So this has to be weighted. The risks of more side effects and the benefits of the medication. So this leads to the fact that the medication in the elderly needs to be reviewed a bit more often, and sometimes you need more monitoring, especially when you have medications which need consistent monitoring, like lithium, clozapine, and antipsychotics. Right, okay. Becoming a bit more specific, so the pharmacokinetics is different. Pharmacokinetics means the movement of the drug in the body. So first thing is how it's absorbed. Usually the acidity of the stomach changes a bit, and for that reason the absorption of drugs is sometimes a bit slower. So you have less blood flow to the guts and less gut motility, so you have a lower rate of absorption, and it takes longer time for the medication to come into the body. If the drug is in the body, in the blood flow, then the changes of the body mass and the body fat, so older people have a higher proportion of fat. For that reason, then the drugs which are lipophile or like fat or like to be distributed in the fat would go into the fat of the body and not float through the blood. So we have also reduced body water and lower albumin. Some of the drugs travel linked to the albumin through the blood flow systems to the places where they want to be or should be. The other thing is, that there's different metabolism. So there's less blood flow to the liver, and usually the liver is the organ which metabolizes drugs and then just uses and prepares the excretion of the metabolites through the kidney. And sometimes the liver microsomes are less active and less efficient, so it takes longer to get a medication out of the system. Right. The excretion is difficult or more difficult if you have kidney problems, and the older you are, the more likely it is that you have kidney problems. So this has been shown that the pharmacodynamics, that's not how it works. So pharmacokinetics is how something goes through the body, and the pharmacodynamics is how it works in the body. And it has been shown that the dopaminergic system has less dopaminergic cells in the basal ganglia, and therefore the body is more sensitive to extrapyramidal symptoms of neuroleptics. The cholinergic system has a reduction of cholinergic receptors, so the receptors might be overworked or whatever, getting too many medication, and then it's the stronger response, or a different or less response, depending on how a metabolite of something sticks to the receptor. Right, the levels of noradrenaline decrease with age, and this can make people more vulnerable to mood disorders. The body is more sensitive to sedatives in the elderly, so even you have a reduced number of whatever narcotics and sedative receptors, or receptors who are responsive to that, there might be a stronger response and people are more sedated. Right, so what are the consequences of that, depending on different types of medication? Certainly, not every medication is the same, but there are some general principles, which means usually in the elderly you start with a low dosage and increase very slowly. So start low, slow, go slow. Then people say, and this is a bit of questionable, that the efficacy, the maximum efficacy is often achieved at lower levels due to the fact that there are different numbers of receptors. However, there are very few studies really showing that. However, side effects are a big problem. If you have effects of a medication on the blood pressure, and elderly people have already more hypertension or postural hypertension, arrhythmia or sedation, then people are more likely to fall. The elderly are more sensitive to extramedullary systems and anticholinergic side effects, and for that reason medication might have stronger impact. I mentioned already the differences of drug interactions due to the common polypharmacy. Atypical antipsychotics are usually better tolerated than the old ones because they have less sedation and less anticholinergic and antidopaminergic efficacy. On the antidepressant side, SSRIs, SNRIs and NARIs are generally safer than the old tricyclics antidepressant, and sometimes monoamino oxidase inhibitors might be a special trial for depression. However, lithium is quite a bit of a difficult one because lithium can be easily overdosed if the kidney doesn't work sufficiently, and it can also affect the kidney in their function. So very, very difficult. But and you can very often see a delirium in people who overdose 1 or 2 tablets of lithium. So very, very difficult. And the other thing is, in the elderly, sometimes they might not speak as often and might not be as dramatic about their suicide intents, but at the end of the day, some of them have a higher risk of suicide. Right, I hope you learned a bit from this video, and I hope that you can recommend our channel to your friends and family, and if you want to subscribe, you're very welcome. Thanks for your interest today, and I hope you have a nice day. Bye-bye.